These are becoming really fantastic lunch and learns that we're really delighted we've got so many people joining us for. So great to have you with us. We really appreciate you spending your time. My name's Jen Kenwood. I'm the Experience of Care Lead for Community Primary and Integrated Care at NHS England, and I have the privilege of leading the Unpaid Carers programme, which, as many of you will know, is largely around the delivery of long-term plan objectives. So it's great to have today's webinar really focusing on one of the key areas of ambition for us, which is around that sort of sharing of information around primary care. Just some housekeeping to set the scene for today. You may have seen already the message at the top of your screen saying that we're recording this meeting. We record all of these webinars and put them on the Futures platform afterwards, so that anyone who's not able to join can catch up later. And also, if you enjoyed it so much first time round, you can have a look again, should you choose to. Obviously, if you don't want to be on screen, please turn your cameras off. As we go through the webinar, we will ask you to keep yourselves on mute. If anyone who's been at one of these before will know that my dog frequently chooses to join the conversation. It's not always helpful, and it can be quite distracting for our speakers. So please do keep yourselves on mute. We will keep questions to the end of the presentation. So if you have questions, feel free to put them in the chat box as we go along. I do keep a note as I go through and try and note everyone that's asked them, so we'll come to you. And obviously, once people have finished with the presentation, you can use the normal hand raising icon as well if you want to ask a question. Any questions that we don't get through, we will collate and ask our speakers to have a look at them and send answers out when we send the link to the recording as well. So hopefully you will really enjoy this afternoon's presentation. I'm really excited about it because I find it really exciting to see how people are actually making things work in a really practical way. So I'm going to hand over to our fabulous carers lead for the South East region, Caroline, who's going to introduce the session for you.
Hi Jen, thank you very much. Hello everybody, and thank you for attending this afternoon's session. My name is Caroline Cameron. I'm the Carers Regional Lead for the South East of England. Today we have the pleasure of having Clare and Ben from Portsmouth City Council Carer Service. And go to the next slide, please. Who are going to talk to us today about carer flags on GP records. Clare is the Deputy Head of Service for Carers, Autism and Engagement, and Ben works as the Assistant Team Manager for the Carer Service. Clare is going to tell us today how they have introduced this system in Portsmouth, and I'll hand over to you, Clare, if that's okay to get started.
Yeah, lovely. Thank you. Thank you for having us. I foolishly put a comment about this in the chat box last time. Can't remember exactly what the conversation that was going on, and then I was pounced upon in a friendly manner. Is this something we could share? So we're very happy to be here today to do that. Ben is going to do a lot of the talking because he is the man with the knowledge, and we have another colleague, Justin, in the room with us to answer any of the very technical queries. But yeah, we're going to tell you a bit about how we've approached trying to make the most of the potential of the shared record system that we have in Portsmouth, particularly around being able to flag carers on GP records. So Caroline's already introduced us, but it's nice to see some friends in the room. I've been the carers team manager for about 14 years in Portsmouth until recently. I've handed the operational management over to Ben. Do you want to say hello, Ben?
Yes, hello everyone. Yes, I've recently taken on some of Clare's work, and I've actually had quite a long-standing relationship with our SystemOne colleagues and the system development, which kind of led into a lot of what we've done from a carer's point of view. So hopefully as we go through, you're going to find it informative.
Okay, so next slide, please. Chris Whitty style. I like it. So just for a bit of background, some of you may already know, but in Portsmouth, we have a carers service, which is part of adult social care. So we operate a little bit like a standard carers centre. We work from a carers centre where lots of community activities take place, mainly run by partners and colleagues elsewhere, small independent groups, that kind of thing. But we're also, that's the base for the adult social care team, who carries out the majority of carers assessments in the city. Like most carer services, we support anyone who looks after someone in an unpaid capacity, including parent carers and other people caring for children. And we have got a good history of working collaboratively with our partners across health, social care, voluntary and community sector. Okay, next slide. Oh, going to appear in a funny order. Okay, click them all up, please. Thank you. Okay, so we're a small unitary authority on a little island city, and that does, I have to admit, make it really quite easy to build and maintain relationships across organisations. There's a lot of loyalty in the city, so lots of people live and work in the city, and that has really helped us in being able to move forward with some of these pieces of work that go across organisations. I mentioned we have a history of collaborative working. Next one. I went back in my ancient email archive, and I reckon we first started doing work with GPs and with primary care about 12 years ago. So it's been going on for a little while. Our first joint carer strategy with our partners in Solent NHS Trust and Portsmouth Hospitals Trust, as it was then, was published in 2015, and we're just near to publishing a new strategy, which is a much more coherent approach across health and social care going forward. So we've started from that baseline. And my personal observation is that when I first started going to GP training events, probably about 15 years ago, with various hats on, one of them being carers, the response that I was getting was, why are you talking to me about this? This is not medical. This is not to do with the patient. You know, why do you even exist in this room? They were kind and polite about it, but there was literally no interest. I last went to a physical GP training session in the summer of 2019, and it was completely different. Lots of enthusiasm, lots of ownership, and lots of commitment to that shared responsibility. So I really do think there has been quite a significant culture change in primary care. So I'm going to hand over to Ben.
Thank you. Next slide, please. Oh, yeah, we're on there. Thank you. So why do we use SystemOne? Well, as part of Portsmouth City Council's Adult Social Care Department, we use the same record system as our community teams, our occupational therapy teams, our continuing healthcare team. And prior to SystemOne, we were using the AIS Swift-based system, but there was going to be a significant reduction in investment in that system. And at the time, in 2016, we actually had a joint service director where we have one CCG and one local authority serving Portsmouth. We had the one head of service, and SystemOne was already being used at the GP practices and in Solent NHS. So following some scoping, we went and looked at a couple of other local authorities. Bradford, I believe, were using it, and North Links were using it. We then picked SystemOne as our preferred option. And then to actually get it off the ground, we had a program manager. We had some subject matter experts from within the business. We had a business analyst and a couple of project managers. But then we used a lot of experience from within the social care team. So we had practitioners from within occupational therapy, within the social care team. I was there looking at it from a carer's point of view to make sure when we developed the system, it had the tools in place that we needed. And I'm sure if there's any sort of practitioners, that you'll realise that what the IT bods think we can do can often be very different, to what we can sort of do as a frontline workforce. So we had to really strike a balance between a technical system that did what we wanted and a functional system that we were able to use on a day-to-day basis. Next slide, please. So the opportunities. Well, we do know that carers often hold lots of information regarding the person they support. We know that they're often having to regurgitate this same information time and again to various professionals that are involved. We know that carers are expert partners, but we also know that that's not always the case across disciplines. It's not always respected, and they don't always have the level of consultation that they want. And so when we're looking at what we can do for carers, and we know that they're often signposted, it's often we'll give a telephone number and expect sort of someone to make that phone call themselves. With the system that we have now, we can see what professionals are involved, what teams, what level of involvement, and if we want to make that referral or we want to have discussion with other professionals in their care, then we actually have a named person, team, contact number, and an effective method of communication. Next slide, please.
Okay, if you click again, I think there's just one more thing on this slide. So SystemOne did seem like a golden opportunity. It's already being used locally. It's got the functionality, most of the functionality that we needed. Nothing's perfect, is it? But it was a golden opportunity to address some of those things that Ben's just listed, but also to kind of really seize on some more of the strategic opportunities by, taking this kind of joined up approach. I don't think anyone was really thinking about carers when they made the decision to go down the SystemOne route. But for us, we really wanted to seize that opportunity and to make the most of it as much as we could, which, given, as we've already explained, we have this unitary authority, one CCG, already good contacts with our primary care colleagues, was going to be kind of easier to achieve than it might have been otherwise. Next slide, please. So we just need to say here, obviously, if you could click again, obviously, sorry, thanks. Having a shared record system comes with it kind of responsibilities and information sharing considerations. So that was obviously worked through alongside the decision-making process to go down the SystemOne route. So every professional in the city who's recording on SystemOne or accessing information on SystemOne will have this conversation with the person that they're speaking to. We use a shared record system here. That means we share relevant information, and it'll only be the only information accessed by any professional will be something that they need to access. So people do have to agree to that data sharing in order to access services. We just thought it was important to make that point. And obviously we explain the benefits of that reduces duplication for people, it improves communication across organisations. And there was some concern that some people might not be happy about this, but actually there has been very, very little resistance. People understand, they have experience of the system and they know how disjointed it can be and how bad communication can be. And actually most people see it as a really positive thing. Next slide, please. This is back to Ben.
Thank you. So the first sort of seeds of thought about having read codes and carer markers on files came about when we were looking at the COVID-19 vaccination programme. So carers fell into cohort 6, and we were asked by the National Vaccination Service to provide the details of carers that we knew were either receiving support from the local authority or who had previously registered with us as carers. And we use markers on our system when we register people to say that they are a carer, but that was information that was held within the adult social care unit of SystemOne. When we ran the first report, we had 1,463 unpaid carers. And because of the way the system's set up, we were then able to easily extract those NHS numbers and compile them and then send them up to the National Vaccination Service, who would cross-check it with the information on who has already received their vaccination before the invitation was sent out. And then that really helped with the early identification and the reduced need for sort of extensive campaign to identify carers. What it also gave us an insight into was where the GP surgeries were at in terms of their own vaccination drives. A lot of our carers that we were putting forward in part of the bulk upload were had already been identified by their GP surgeries. So we knew they were capturing this information, but we didn't necessarily put the two and two together at the time and say, well, if you're capturing it and we're capturing it, you know, how can we actually make it so only one of us needs to do it and we can share the information? And the only other thing it gave us access to as well was we could then use those markers on people's files to allow them to attend walk-in vaccination clinics, because we were actually able to provide evidence that they were a carer. Next slide, please. So the principles behind our decision making, as I've just sort of previously alluded to, it's say it once. Carers can register at their GP as a carer, or carers can register with us at the carers service, and that information will be shared across the system. Improve visibility. So GP practices were finding their list of registered carers were going from the 10s to the 100s. You know, it's not that they weren't necessarily supporting them, it's just that there wasn't a method in place for recording it. Enhanced promotion of carer welfare, wellbeing and health checks. I'll come back to it in a second when we look at a case study. And there's also that streamlined flow of information between the organisations. Again, that all comes back to sort of the say it once principle. If they're coming to us and they're saying something and it's relevant, then that information is accessible across the system. The only other thing is we have, where we are part of the social care teams and we are using the same system, we have agreed language with our GP surgeries. So if they want to know if there's a package of care in place, or if we're providing respite breaks or some form of a sitting service, something like that, we record it in a specific way on the system, so GPs are very easily able to search using keywords so they can find out what care is in place from adult social care. Next slide, please. So this is just a very brief case study with one of our PCNs. After we'd identified the carers and we'd uploaded the information, they used that to then provide specific and bespoke carer services. They have 6 GP practices, and every 2 months in a different practice throughout the year, they hold a carer coffee morning. That will then include health checks. We will be represented and they'll have information on support available through the Portsmouth carer services. It's also an opportunity to meet the carer leads from their practice. Next slide, please. Okay, so this is where we look at the process of what we've done, and this is where I expand to the limit of my technical knowledge. If there are any more in-depth technical questions, obviously we will look to answer them. So first of all, we scoped the registered carers on the SystemOne module, and we held a discussion with our GP SystemOne user group regarding the suitable read code. There were more than one that were being used.
So age 43, I am having.
Oh, So yeah, once read code was agreed, we as a carer service completed the data cleanse. And once that was done, we had a bulk upload of the read code based on the cleansed data. We did get some errors back from GP surgeries. Information is only as good as what we're putting on the system. So we weren't aware in all cases situations had changed, but as a rough figure, we had about 2% of the records that we marked returned to us in error, to then sort of have a look and see, are they a carer, yes or no, and do we need to change that read code? Next slide, please. So just the current historical data, and a kind of caveat around this is it's very new. We've been putting the read codes on now for less than a year. It's not something that we can evidence in, other organisations maybe setting a precedent that we know about. It's not to say it doesn't happen. But when we first looked at it, we had a total number of 2,629 carer registrations since 2019. Now, just also as another little aside, when we moved over to SystemOne, because of the information that it holds, we don't hold live records anymore for people that we are not actively working with. So you may come to us and you may get a short-term support. Once that short-term support is completed, all that information is then returned to the main spine of the database, and it's no longer visible to us because obviously there is GP information there is health information. If we're not actively involved, we don't keep that on our module of SystemOne. And prior to that, we had over 5,000 before we migrated the relevant data over. So at the time of adding the read code, we had 1,428 active carers that had the code uploaded. And then since then, we have had 69 that we've indicated they are no longer a carer. That's not 69 that we're no longer working with. That's 69 that we are aware their caring role has ceased for one reason or another. So next slide, please. So there is now a second read code. This read code indicates that someone is no longer a carer, and we added that in December 2021. So the rationale is that if someone is no longer a carer, then we need to mark that. That needs to be visible on the screen. But what we don't want to do is remove that read code from the system, because you're essentially saying, I'll take that off the system. According to the system, then that never happened. That is not marked that person was once a carer. And also it removes our ability to examine historical data. We can't look at previous past trends, etc. So we very much need that ability to say something did happen, but we're not going to then take it away and remove that. So that's the reason why we had the second read code for no longer a carer. And it wasn't actually, as I say, this is new to us. It was something that was pointed out. As I say, it wasn't something that we set up at the beginning and then it was highlighted, and we kind of thought we do have something that we need to address here. So yes, next slide, please. So challenges and limitations. So we work in partnership with the CCG and the GP surgeries. We work in partnership with our colleagues at Solent Health. We also work closely with our colleagues at Portsmouth Hospitals University Trust. But they're not on SystemOne. So this information that we input doesn't cross over to the acute trust. So if someone is admitted to hospital, there's not a system in place at the moment that will allow us to automatically transfer that information about whether someone is a carer or whether in fact someone being admitted has a carer. Another of the challenges, there are high numbers of staff accessing and editing information. across all the different organisations. That does in itself present challenges in keeping things accurate. Our SystemOne support team have produced a number of reports that we run that will identify potential errors, and then we can interrogate those reports and hopefully cleanse to the best of our abilities. And the other thing we have is that it's not suitable for carers living outside the PO1 to PO6 boundaries. One, the GP practice, the health setting may not be on SystemOne. They may use other systems, may be unable to access the information. They also are not signed up to the information sharing agreement. So if we access a record for someone who sits outside of our PO1 to PO6 boundaries, which we may well do because we're set up to support carers based on where the cared for live. So if your cared for lives in PO6 but you live in PO7, when we pull your record through, we would only ever be able to see information that we as a local authority record. We don't have access to any GP or any other health information. And the other challenge, but it's certainly not a limitation at the moment, is this is still a very new system for us and for the GPs. We haven't, as I said before, got a sort of a precedent to follow. So we very much see how things pan out. It does work well for us. Certainly we find there are lots and lots of advantages, but we are kind of seeing how things go, and it's by no means a finished project yet. Next slide, and I'll hand back to Claire.
Thank you. This is our last one. So just a few next steps for you, really. We are working alongside CCG colleagues at the moment, the primary care leads there, to re-establish the Sequin for carers work, something that had fallen by the wayside a little while ago, and that this has kind of pushed it up the priority list. So that's been quite helpful. We are looking for other opportunities or looking to develop the idea, the many ideas that we've had. And one of those things that has recently been technically put into place is the ability to make e-referrals, really quick referrals. So a GP's having a conversation with someone, there's a conversation about the fact that they're a carer. Historically, what most people in primary care have done, what most professionals in primary care have done, is to give a leaflet or say, hey, you should go to the carer centre. We know that signposting is often ineffective, so we've been trying to look for opportunities, easy opportunities, knowing that no one's going to fill in a long form. Some primary care professionals are really good about proactively emailing us and saying, I've just met with this person, they would like you to contact them. But actually, we think that this e-referral option on SystemOne is much easier, much more systems based. You can see it all within the system, so there's a record of it. So that is just about workable now, but we haven't actually really started using it. So that's kind of a next step. We want to build on the success of practices who have already picked up the NHS England GP quality markers from a couple of years ago. And Ben referred to the Portsmouth group practice. Really, they're the main practice group who kind of picked that up and ran with it. So, you know, there's been a pandemic in the interim. It's not something we've revisited with them recently, but we would like to do that. We are continuing to improve care identification in primary care at a more operational level. So the ongoing conversations with practice managers, with practice staff, taking any opportunity that arises to kind of flag up the need for better identification. And obviously on the horizon, everything's going to look a little bit different at the more strategic level. So we really would like to see that if we can embed more systems-based approaches to care identification and referral through to support, kind of get that embedded in the new ICS, ICP, whatever landscape. I think that's it. Next slide. Yes, thank you for listening to us. Bit of a
Thank
gallop
you
through
so
our slightly cobbled together approach to this, but I hope that was useful.
Not at all, Claire, and that was absolutely fantastic and great just to kind of reflect on some of the things that you were saying about being able to view things as an opportunity. And I think that's been one of the things where carers have probably done it better in that way for longer than pretty much any other part of the system, because we've been so used to having to work around things. Actually being able to see that challenge as an opportunity is really helpful. And I also think really heartening is that enthusiasm rather than resistance that you experience, that people thought actually this is solving one of the headaches that we've had around that sort of disconnect between parts of the system.
Yeah, we do like to say to our colleagues, hey, there appears to be a bit of a problem here. Don't worry about it. We can help. And then you kind of get your way.
I know, it's the carer's way, isn't it? Go in with a
It
smile
is.
and people can't say
Yeah,
no.
absolutely.
Apologies for my moving door. That was the dog I warned you about earlier. So we've had a few questions come up and I've seen some hands that have pinged up and straight down again, but we'll come back and ask that. So Sonia had asked a question around how you worked around GDPR. Sonia, I don't know if you want to hop in and ask that question a bit more fully.
Yes, it was one Ben mentioned the, apologies, I can't remember how you named it. I think it was
read codes, I think, wasn't
read code.
Yeah.
And no read code. I was wondering, because obviously when somebody stops caring because of the person they care after dies, or they just simply stop caring, and then further down the line we have to anonymize those records. I mean, I was wondering how keeping them in two parallel systems works with GDPR, and what's the amount of information that you keep? How do you anonymize it, and how does that work?
Yeah, so all of our records are pulled through from the central spine. So it's the same record, you know, that depending on who you're working with, whether it's the GP practices, whether it's with ourselves. But what it does is it takes information from the spine, and we can then access it through our local module of SystemOne. We can, when we're working with someone, we obviously have access to that record. We can record on it, and then once actually that work is finished, then we deregister them from our system, and that takes everything we've input and it puts it back into the central spine database. Once it's there, then we no longer as an organisation have access to it. And if we start working with them again for different reasons, obviously we do it from a carer's point of view, but they may then become involved with adult social care, occupational therapy, etc. They then once again retrieve that record back from the spine. They retrieve the information, but the entire time that they're not registered with us, we don't have access to that information. That's held centrally.
Right. That's helpful. Thank you. Yeah. Thanks, Ben.
So in turn, that would be explained as well when someone accesses any service that is recorded on SystemOne, that conversation takes place. This is how we record your information. We do share information that's relevant. No one will access your information unless it's relevant to something they're doing specifically with you. So people do have to consent to that. But like Ben said, that file won't be open to someone unless that team is actively working with that person.
Thank you, Claire. That's very helpful.
It might be important, sorry, just to add that there is an opt-out. If you're having a service from us, then we can't really provide that service if you opt out of sharing any information with ourselves, but you can opt out of us sharing any information with the wider system users. So we can adjust the access privileges depending on people's choice.
Brilliant, thank you. And I think from my perspective, really helpful that you're still keeping an eye to those people whose caring responsibilities have ended. There was some research that the Open University did a few years back, wasn't there, that looked at the health outcomes of people after caring for someone, and it really clearly showed that actually there was no improvement in their health and well-being because caring had stopped. Actually, the same impact was being realised by those people. So great that you're keeping that in mind. So we had two questions from Linda Hughes, one around the context of this sharing of records, and is it the same as the planned shared care records between local authorities, health, and the voluntary sector would also be able to access? And also a question about hidden carers. Linda, did you want to come in?
Well, thank you very much. I mean, I was looking at the priorities which I hear from all the carers I talk to, and we all know that not having to tell your story more than once is so important. And I wasn't sure, because it also interests me about minimum data sets. Exactly, were we just going to pool things together, and how is it going to work? I mean, I'm so interested in this because it is the SystemOne, it is holding data that's already on the GP surgery, but I'm not sure how that then ties back in to future data development. This sort of thing tends to be rather top-down, worked out and imposed. And another question on the top of that was, I mean, for me, so much is done for the patient, but neither they nor the carer normally can input into the system. So it's a professionals system, whereas I think now we're working much more to wanting, having read the Working for People and Communities 72-page document, more from people coming into that. And the third thing was about hidden carers, because the vast swathe of carers that are not on our books in Devon are, in my estimation, and probably others, those who say, I'm not a carer. No, I never said it. You do what you do for love. And no amount of saying you're a carer can make it be so until there's a crisis, and maybe you can persuade them. Thank you.
Okay. Shall I start with the care record stuff?
Yes, go for it.
I mean, it's absolutely, you've said it all, really. I don't know that we're any further on than anyone else in that. There's probably other people who are already cracking on with that stuff. It's definitely been in discussion for some time. I've been to several workshops probably over the last 5 or 6 years where we're kind of revisiting these ideas, and I guess SystemOne is maybe our first step locally. I know we've been talking about access to care records. There was a pilot in Portsmouth around domiciliary care where carers and other professionals, named professionals, could access the domiciliary care record so that they knew, you know, for distance carers particularly, that kind of thing, they knew what care and support was happening. So it is something we're very aware of, something we've piloted some approaches to. You know, I think, again, it's something the pandemic has scuppered progress on a little bit, but it's definitely on the agenda. And wouldn't it be amazing if we could all go into our NHS app and see everything that's going on with our care and support? I think that's the aspiration, isn't it? And that was reflected in the Data Saves Lives document, whatever it was, thingy. I mean, I think for hidden carers, you know, we try and take an approach in the carer service where we say, do you look after someone? You know, could that person get by if you weren't around? And we try not to label. You know, lots of people don't like any of the labels they're given by us in the public sector. So we do try not to label, but you're right, there is a chance that there could be people that say, I don't want that flag on my record. Why are you even saying that to me? You know, and that's personal choice, isn't it? I think all we can do is to have those person-centered conversations with people about what's going on for them.
Could I just add a quickie? Am I allowed?
Yeah.
Yeah.
Thank you. Sorry, I don't want to argue anything. We had this huge discussion about the phrase unpaid carers, which was frankly found to be insulting by quite a lot of people. We understand why it's there. But in fact, one of the things we came up with was if there was more use of the word care worker to distinguish between a carer, because the public has a clue, not a clue. They don't know which is which. And so carer doesn't mean anything to them. The other thing we did was we all adopt now our own adjective. So if the patient thinks you're their carer, you'd proudly announce yourself as you are their primary or principal or family or friend carer. So you put that adjective in front of the phrase. And again, that helps to distinguish it, because one of the biggest problems we've got, I think, is that people do not distinguish between those who are a care worker and not otherwise. So I think that's two tiny things we're doing that might help.
Yeah, absolutely. That's something quite a few of us on the call are involved in the world of policy stuff around carers regionally and nationally, and that's something we do bang on about.
Yeah, I think you've
but it's
echoed a very regular theme through these calls. And I think part of the challenge is that because the word carer is used in legislation, that's what we've tended to use outside of it as well for consistency. But actually, when you're in a very practical situation working with families, you use the phrases that are going to be helpful and useful to them. And the C word isn't helpful. It's certainly not how I viewed myself either. So yeah, absolutely. So I've got one more question that was from the chat box.
Could I just, sorry to interrupt, Justin popped his hand up. He's actually our SystemOne support team, so he may have some further information on Linda's questions.
Okay. Justin, do you want to hop in?
Thanks, Ben. Yeah, it was really just to reiterate something that was mentioned in the presentation, actually, and it was about these unknown hidden people in the, across our city, and obviously across every city, really. I think one of the ways that we've tried to make that connection, I guess, with the people or the service that can help those people is something that Claire mentioned, which was electronic referrals. So within SystemOne, every single primary care colleague, whether that be a receptionist, a GP, a nurse, our community care colleagues, everybody that was with a person that is a resident of Portsmouth that suddenly mentions something that indicates that actually the service, the carer service could and should be something that they should have that discussion with, has the ability literally to click 2 buttons and it's kind of in process, and I think that I'm sure as time progresses will boost the numbers probably even further for Ben and Claire's team, and it is just adding to that whole ethos of okay, it may not be to do with you as a GP primarily, but actually let's make it to do with you, but make it easy for you to do something with, rather than make it so hard that you'd probably be more inclined to say, I've only got 10 minutes for this consultation. I don't have the time. So that kind of use of SystemOne around able to, quickly get people into, to the right place, should make a massive difference in time.
Yeah,
I would say.
It was the first thing I got excited about when we started talking about SystemOne. And, in practical terms, that means, I don't know, the psychologist from the chronic pain team. It means the physiotherapist out in the community just doing one session, teaching someone how to do some exercises. It's the podiatrist, it's the community nurse, it's all of those people who the vast majority of carers will come into contact with one of them in some way, shape or form. As Justin says, the potential for that is huge. A bit worrying, even in an exciting way.
Thank you. And I'm very impressed that you're openly admitting to your excitement about data stuff. So the other question that came up in the chat box, which I think is a really interesting one, and I think one of the things that would actually benefit health colleagues a lot, particularly when you think of the moves that are being made around social prescribing and those more, the less medicinalised or medicalised interventions that are being promoted within primary care now. And Amanda Emerson had asked about whether health colleagues were, through this system, had access to carers assessment information. Amanda, I don't know if you want to come in at all and ask anything sort of more broadly around that.
Well, no, I think that's pretty much it, really. But obviously, when you're talking about people having to keep repeating their story, and obviously, it can gain, the information contained in a carer's assessment is really comprehensive. So I just wondered, how that works really for you in your area.
Do you want to make a start on that, Ben?
Yeah. Yes. The short answer is yes. That they can access the information on a carer's assessment. What we have is the challenge around education when they can access it. It's there, we always have this hesitancy, and we all do it, of it's a confusing world, GDPR. You know, it's do we have permission to be looking at this? But yes, certainly within the system, they have access to see the assessments and the questionnaires that we've completed. Our assessments don't necessarily, well, they're not form-based. We do have a questionnaire that we will input onto the system, but we may do a carer's assessment without completing that. You know, it's proportionate, it's scalable. We may just put a detailed progress note on the system to say what, you know, conversations we've had, advice we might have provided, and that is visible across all the users via what's called the tab journal.
Yeah, I think the challenge is people knowing to look for it and then accessing. You know, there's less of a challenge, I think, with people accessing appropriately. It's more like they won't do it because they don't know, or they think they're not allowed to access that information. And you'd hope they'd have that conversation, obviously, with the individual.
Yeah, and it was interesting to note that, you know, the health colleagues can just go into your system and think, oh yeah, there's a package of care in place. You know, things like that. It's obviously really helpful when you can access that information so quickly. So thank you for that. That was really interesting presentation.
And it looks like
Thank
Justin's hand is up again. So something to add in, please hop in.
Just going to add as well, because, you know, Portsmouth did a massive amount of work really to get all the primary care and community care onto the same system back in 2015 or something. I think it was 2016 maybe, with adult social care coming on a little bit later. But being able to see who's involved with a client or a patient or someone in the community in terms of the services they're receiving is a really, really quick and easy thing to be able to see. It's then, as Claire said, it's then just being able to put the two and two together and locate the information that's related to that service. But it's very, very simple. If somebody's under the carers team, for a primary care or community care colleague to instantly see that they have active involvement with that service. So that should then make it a little bit easier again and give them that confidence that they have got the information they need to hand.
Thank you. One of the things that's come up in the chat box is a comment from Alan Pickup. I can see you on my screen again now. Who I think has reflected what a lot of carers have experienced, that he's had many, many years of caring, but never actually was offered any of the sort of support we've been talked about. And Alan, you might want to come in, but I think for me there's a question about what sort of training and preparation is being given to people across the system so that they're having the right type of kind, compassionate and productive conversation, so that people are actually identified and it's not just reliant on us having a system that talks to each other. It's about people talking to each other and actually doing that recognition and thinking about, well, the so what, you know, what are the health checks, the carers assessments, all of that. Alan, I don't know if you want to come in as well.
Yeah, I can comment on it. As I say, I was working in health. I retired in 2010, and as I said at the time, we were looking at Care Trust Plus with the Care PCTs and the social services trying to work together, and it still didn't come off. When I did retire, I started caring for my father-in-law who had dementia, and we needed to contact social services, and they came living with us, and they came and they looked at what was needed for us to cope with him, but at no time was it mentioned that I was entitled to a carer's assessment. You know, and it was only by chance that, as I said, I've been caring for my son for he's 48 now, so he has learning disabilities, and it was only by chance that I was contacted by the learning disability team, the local authority, who were starting a separate section for carers of people with learning disability, and it was run by our local carers service. So I went down to find out what it was all about, and now I'm chair of the care service. I believe in it so passionately that what they're trying to do. So as I said, there's still a long way to go, and there's such a discrepancy between what is being provided. I mean, so we're a carer service, but we don't provide the statutory assessment. The local authority won't release the statutory assessment because I think they're frightened of what burden it'll place on them when people realise what they can get. You know, we have more of a signpost and peer group sort of support. So I think we're still a long way to go. I'm also interested in what we're saying about the you know, the system approach in Portsmouth. It sounds very good. I was involved in NHS Direct and all the other linking systems up back when I was working, and it was a nightmare. You know, we actually had, when I was working, we actually had to act as in between. I was running the out of hours doctor service in our part of the country, and we actually had to act as an in-between between the GPs and the ambulance service because they couldn't share records. You know, talking about the DNA CPR records, that doctors couldn't share them with the ambulance service, but we could share them with the ambulance service, and the GPs could share it with us. So, you know, there's milestones to get over, and I just hope that I see it in my lifetime that we do get it finally right for people. So I've had my rant now.
I mean, I feel the same,
At
Alan.
all.
You know, I feel like I've got a long time till I can retire, but at times you worry that you won't achieve everything because things do take so long. But I do think the direction of travel is right. I think around the data stuff, you know, the data saves lives thing. What was it? I can't remember exactly what type of document it was, but anyway, it covered a lot of what you were just mentioning there, Alan, and that's something we kind of have in our minds in Portsmouth about, you know, taking these opportunities. But there still is that disconnect with the acute hospital trust and ambulance services and so on, exactly as you say.
I think that's absolutely right, Claire, but I think we've seen over the last 5 or so years in particular some really different working within systems, and hopefully those who've been to a number of these events will have seen it, and I can see familiar faces like Jane from up in Liverpool, who's done amazing work around more integrated system and more cohesive working across systems. So I do think there is a little bit of a tipping point, and you're right, it's very slow, but it is shifting. I think the Royal Assent on the Health and Care Bill is helpful because we have carers more specifically referenced in there. So there is a move towards levelling up health sector alongside local authority. It's not as far as any of us would want, but I think we also need to be aware that legislation isn't the only answer. It's about how we work and how we have conversations with real people in front of us. I'm conscious of time, and so I think we've got time for one last question. I can see Ron with his hand up. Ron, can we come to you?
Yeah, thanks, Jo. Just really, I suppose something on the side, around I think about 7 million people go through private healthcare every year. And I don't think we've ever really grappled with that. Certainly there'll be carers in that sphere as well. And I just think that may be the next point of contact, that we need to engage the private providers to encapsulate those carers that are in the private sector as well. How we do that, I don't know, but I think we need that conversation at some point.
Yeah, I think for the way things work for us in Portsmouth, because we are an outstation and we're a specialist team within the local authority, you know, people come to us in the same way that they might a voluntary sector carers service, but we can, you know, we obviously don't want to suck people into the system, but we can maybe provide access to things that they might not have been accessing because they don't have a social worker, for example. They've sourced their own care and support, and as you say, potentially even private healthcare, so they're not touching that part of the system either. And I do think this is where a broader approach involving voluntary sector providers, so they might be getting some advice from Age UK, or they might be getting some advice from one of the other charities that's condition specific or something. And if we have those really good links, you have greater potential maybe to get the right support to people where they want to access it, rather than everyone having to come through a Care Act assessment. Not everyone wants a Care Act assessment. We need to be proactively offering, because that's what the law requires of us. But actually, you know, it's an offer. It's not you have to do this in order to even be acknowledged as someone who's providing care and support.
Thanks, Claire. And Ben, that has been, I think this is one of the liveliest ones that we've had so far, so fantastic. And I think some really interesting discussion, not necessarily around questions, that's come up in the chat box as well, and particularly from our lovely friend Jackie Darlington, about the confusion between carers assessment and carers allowance, and people think they're going to be means tested for a carers assessment, which is absolutely not the case, and will put lots of people off. And I think just the stigma of the word assessment isn't helpful either, is it? It implies someone's going to judge you on your caring, so really challenging. Lots around language, and Linda, some really helpful comments as well about single points of contact. I think the key one that I know in terms of a single point is where I live, actually in Hertfordshire. If you Google carers in Hertfordshire, you get a website that if you register once on it, it will put you in touch with your GP and the local authority and the carers organisation in one hit. But obviously you have to be IT literate to do that. But what I think is great is that in our local library, we have lots of posters around, you know, do you support someone at home who wouldn't manage without you? And actually all the staff there have been prepped to help people register as well. So I think it's difficult, a thorny issue. We're certainly not going to solve it this afternoon, but a huge thanks from me for your presentation. We will pull together the slides and the recording and get those out to everyone. And if I have missed any questions in the chat box, I apologise. We will go through again and make sure we include any last minute questions so that we can further torment Claire and Ben and get all of their knowledge and expertise out. But that's it from me. So I'll hand over to Caroline just to say a final thank you and goodbye.
Thanks, Jen. Thank you, Claire and Ben, coming today and giving us a wonderful presentation, and also inspiring lots of questions around the system that you're developing. And I look forward with working with you going forward. So thank you, both of you, and you can relax now the rest of the afternoon after getting yourself all prepared for today. So thank you very much, and thank you everybody who's come along. And
thanks for having us.
Yeah,
and a timely reminder from Jackie again that we have Carers Week looming fast, so let's make use of the theme to its full. Absolutely agree. There'll be a number of us on the road and doing different things around the country, so let's really make ourselves visible and unavoidable. Okay. Thanks so much, everyone. Have a great rest of the day and look forward to seeing you next time.
Thank you.
Bye.
Bye. Bye.
Thank you.
Bye.